That's your presentation.
This is here.
Yeah.
I don't think is it on?
Yes.
Can you hear me? No, I don't think this is on. Well, these are not here. Okay, no. Good morning, and again, thank you, Wanda. Yes, I stumbled and got lucky when I met Florida Allergy Coalition. Look, I was the president of the State Society in 2018, and I am embarrassed to tell you, and I'm not the only president, I'm not the only membership person, it's just a remarkable. And I am grateful for stumbling and meeting Wanda and Shelby and bringing me into the family. And yes, I think this can be I think it was the last scene with Humphrey Bogart and Paul Henri Casablanca. I think we're going to have a great friendship. I think that this is an opportunity to form a tremendous alliance with patients and compassionate awareness to understand that asthma still kills. And we're here to kind of change this perception about control of asthma. I'm grateful to my colleagues at AstraZeneca and all of the AstraZeneca family for affording me this opportunity to discuss with you a very important topic that I think is going to set the tone for this illustrious meeting that you have today. Again, thank you, Wanda, Shelby, and all who have been involved with this coalition. Today, we're going to be speaking about the current misperception of asthma control using evidence-based tools to advance the identification and management of uncontrolled asthma across disease severities. The objectives of today's talk is to recognize the burden of uncontrolled asthma in the United States, heighten awareness of patients and clinicians' overestimation of asthma control and the consequences of short-acting beta agonist utilization, exacerbations, and systemic corticosteroid exposures, and learn how the AIR-Q and accompanying evidence-based educational materials can help identify and act on controlled asthma. And I think that you all have by now a copy of the AIR-Q, the Asthma Impairment Respiratory Questionnaire, which I will be referring to later on in the talk. Please open your browser and navigate to this site, or you can point your phone's camera at the QR code. You have a chance to do that. It's just for a pre-evaluation survey. So what is Precision? Precision is an unbranded initiative dedicated to improving the identification and management of patients with uncontrolled asthma. AstraZeneca united a network of more than 200 advisors across all disciplines, physicians, allergists, immunologists, pulmonologists. We had nurse practitioners, physician assistants, respiratory therapists across the United States who directed and informed objective and initiatives of the Precision program to help address the unmet need of asthma. And Wanda was beginning to go there, that there's still a tremendous prevalence of asthma in the United States. Approximately 25 people in the United States are living with asthma. 60% of adults currently have what is considered uncontrolled asthma. 44% of the kids have uncontrolled asthma, and 65% of patients over the age of 12 at some point have used steroids. And you're going to hear me becoming very repetitive. So as a native New Yorker and a Latin from Manhattan, I speak very quickly. Remember, I spent a lot of my life on the subway, so now we're starting out at 180th and the A train, and now we're going to head on the express train to 59th Street. If those of you have any idea what I'm talking about, but do it, you'll understand. So again, this bar graph illustrates that about 8% of the population in the United States are living with asthma. Asthma prevalence has leveled off over the past few years, but it hasn't gone down. And millions are reporting exacerbations, missed schoolwork, missed school days, work, and remarkably, despite our incredible advancements that we've made in terms of diagnosing and managing asthma, deaths rose for the first time in 20 years in 2020, and people were staying home during COVID. So we have dual controllers, triplet controllers, biologics. Asthma deaths have gone up. We have got to do better. The projected health and economic burden of uncontrolled asthma, it doesn't appear too bright from this, according to this modeling study. Asthma prevalence is expected to increase by millions over the next 15 years, and more than half of patients with asthma will be uncontrolled. And it's going to get very expensive, with a projected cumulative total direct and excess indirect costs approximating $1 trillion. And we need a new approach to the identification and management of these patients. Without a change in disease control and adherence to evidence-based strategies, the future as projected does not appear to be too bright, but we're going to find a light at the end of this tunnel. So airway inflammation, I tell the residents, it's like a submarine. It runs silent and deep and is central to asthma symptoms and exacerbations. And we're all aware the driving force behind the clinical expression of the asthmas. So there's more than one asthma. It's the asthmas. This is a syndrome, is inflammation. Inflammation can be triggered by allergic or non-allergic exposures, and it drives the airway narrowing from bronchoconstriction, mucosal edema, thickening of the airway epithelium, and fibrosis. Both airway inflammation and symptoms vary over time and intensity, and may be driven by episodic exposure to these allergic or non-allergic triggers, leading to an exacerbation. But these episodic triggers are often unpredictable. So, we can't always depend upon that, yes, I'm going to have a certain exposure and then I'm going to make sure that my asthma is controlled. It can happen in people that are very vulnerable to this unpredictable exposure, causing an exacerbations. And while symptoms may come and go, underlying airway inflammation persists. So these are newer concepts as we're advancing our understandings in terms of step one controller therapy, which I'll reference in just a moment. As you can see here, patients often characterize, it's like when they have asthma, it's like breathing through a straw. Regardless of whether you hear it or whether you feel it, inflammation is a silent menace, and it's poised and ready to strike and lead to an exacerbation. The absence of symptoms is not the absence of disease, as illustrated in this endobronchial biopsy of an asymptomatic asthmatic. And take a look at the structural changes to include epithelial disruption, thickened basement membrane, and an inflammatory cellular infiltrate consisting of eosinophils and neutrophils. Even in patients with apparently so-called mild asthma, there remains substantial risks for serious events. In one such study, 37% of asthma-related emergency department admissions were in patients with mild asthma. 16% with mild persistent asthma had at least one exacerbation in the previous year, and 60% of patients with intermittent asthma had at least one exacerbation in the previous year. Asthma is a spectrum of diseases, and it's not a one size or one asthma fits all patients. And regardless of the underlying drivers in asthma, whether it's, you can see, allergic, eosinophilic, non-allergic, non-eosinophilic, there are various triggers that can incite a rise in inflammation, which can lead to less than optimally controlled asthma and an exacerbation. And while symptom expression is variable for the individual, inflammation is present to some degree. So just because you don't see it and you don't feel it, don't think for a second it's not there. Despite our good intentions in prescribing maintenance therapy, real-world use of anti-inflammatory maintenance therapy does not eliminate the risk of exacerbations. And this study of more than 135,000 patients with asthma from a large research database examined asthma control as measured by prescription fills of short-acting beta agonists. As you can see on the left side of the slide, they considered one prescription fill a year to indicate well-controlled asthma, 2 to 3 to indicate not well-controlled, and more than 4 prescription fills a year to indicate very poorly controlled asthma. The authors also examined adherence to maintenance medications in the center of the slide. And on the right part of the slide, the percentage of patients in these categories that went on to have more than one exacerbation per year. And they found that regardless of the SABA exposure, the level of asthma control, or high adherence to maintenance medications, still around 50% of patients with asthma experienced more than one exacerbation per year, demonstrating that all patients, regardless of their level of control, are at risk for an exacerbation. Asthma prevalence and morbidity were identified using a medical and pharmacy claims database of about 4.5 million patients. This is a heat map, and it ranked the prevalence of severe uncontrolled asthma in all 50 states, District of Columbia, plus close to 3,000 counties. As you can see, the darkest colored counties, or hotspots, represent the greatest concentration of severe uncontrolled asthma. There is not a spot or a hotspot where severe uncontrolled asthma is not. In this study, 15% of all patients with asthma who were uncontrolled, as defined by more than 2 bursts of systemic steroids, were found in this group. 14% of patients were treated as severe asthma, according to GINA's Step 4-5 guidelines, and approximately 3% were found to be severe and uncontrolled asthma. The point is that local awareness of systemic steroid use as an indicator of uncontrolled asthma should prompt regional efforts to improve asthma control. And I think that from the little that I'm learning now about, well, actually, the more I'm learning about the Florida Asthma Coalition, I think this is where you're going to make some of the greatest impact to helping us recognize these hotspots. There exists a common assumption that uncontrolled asthma is reflected in the highest level of disease severity. But severity is only a measure of which controller medications a patient's prescribed, and not a measure of whether these medications have even helped the patient to control their asthma symptom impairment while reducing the risk of an exacerbation and systemic steroid exposure. It's only when you define control by both risk and impairment can you fully appreciate the magnitude of uncontrolled asthma. So while much of our focus has been on Step 4-5 severe asthma therapy and to include the use of biologics, and I can tell you as a physician, this has been the bane of our existence since the tsunami wave of biologics hit the market in 2015. We have put our emphasis on severe asthma and we forgot about everybody. What about us? What about us? So results from a large medical and pharmacy claims database reminds us that most uncontrolled asthma occurs in patients treated for mild or moderate GINA Step 1, 2, and 3 disease, and not Step 4 and 5. This slide speaks to the consequences of treating exacerbations with systemic corticosteroids. I refer to this as the era of commission. I dare say that most of us in practice have been faced with committing our patients to systemic corticosteroids to address an asthma exacerbation. And doing so can result in a cumulative corticosteroid burden that affects both current and future health, increasing the burden of an already burdensome disease. So as you can see, cumulative systemic steroid exposures of more than 500 milligrams to 1,000 milligrams are associated with adverse outcomes, including type 2 diabetes and anxiety and depression. But once you start crossing the 1,000 milligram threshold, this brings additional risks of developing renal impairment, cataracts, osteoporosis, immune suppression, adrenal insufficiency, and all the et ceteras that we take for granted. And it really only takes a very little bit to increase the risk of adverse health conditions. So when addressing an asthma exacerbation, guidelines have suggested steroid dosing schedules anywhere between 40 to 60 milligrams a day for 3 to 10 days. Now, depending upon training and experience, this may translate into 20 milligrams twice a day for 5 days for a total of 200 milligrams for just the first burst alone. But that's considered below the threshold. Others, however, may recommend 60 milligrams a day for 10 days for a total of 600 milligrams for the first burst. And now you've just crossed the threshold. You can see how little it takes to start crossing those significant cumulative thresholds while increasing the risk of these disease states. But remember, that patient is also going to urgent care, emergency room. They stockpile their prednisone. They get it from their friends. They get it from the squirrels that stockpile the acorn steroids. And so this becomes a cumulative effect that is very easily surpassed over that individual's lifetime. So we've just talked about this understanding of exacerbations and the consequences of committing our patients to systemic steroids. This slide suggests there may be a window of opportunity to help prevent an exacerbation and avoid the need for systemic steroids if symptoms and inflammation are treated concomitantly. I've given this talk before, and this graph reminds me of an iceberg, the tip of the iceberg. Again, with the Titanic, by the time the captain saw the tip of the iceberg, it was too late. Here you can, the correlation is that this is the tip of the iceberg is the onset of the exacerbation, the recognition, and then the exposure to the steroids begins. But as you can see, this baseline is really not zero. So this iceberg is sitting on, I call it a sea of inflammation. We're talking about symptoms here, symptoms that go up, symptoms that go down. But there's this inflammation that still stays at the bottom of the ocean floor. This graph was taken from the FACET study, published in 1999. It's an exacerbation reduction study in response to inhaled corticosteroids with and without long-acting bronchodilators in 852 patients who were followed with more than 400 severe exacerbations over a 12-month period. And the authors defined a severe exacerbation as one requiring oral steroids or an episode in which morning peak flow dropped by more than 30% below baseline. And the authors examined patterns of morning and evening peak flow, day and nighttime symptoms, and rescue medication use. They noted a crescendo or worsening of symptoms, a decline in peak flow measurements, and increased rescue use about 10 days prior to the peak, when the exacerbation was finally diagnosed and oral steroids were initiated. And the decrescendo or return to pre-exacerbation levels occurred over the subsequent 2 weeks. So as we see, asthma is a variable inflammatory disease. As the inflammation rises, so do symptoms and the use of rescue therapy. And there may be this window of opportunity to treat symptoms concomitantly and mitigate a rise in airway inflammation to prevent the exacerbation. The NAEPP and GINA guidelines support ICS and fast-acting bronchodilators for patients greater than the age of 12. And I always say, my goodness, things have changed since the early days of the asthma guidelines starting in 1991. Some of you may have been in preschool. I was, and rocking it some other way, I was rocking it as a younger attending. And in 1991, Bohemian Rhapsody by Queen was #2 on the Billboard Top 40, and was one of my favorites. So as I'm making rounds with the kids, I'm Mamma Mia, Mamma Mia. So As you can see, both the 2023 GINA guidelines for asthma and the US National Asthma Education and Prevention Program in 2020 focused updates advocate a rescue therapy strategy that's based upon treating symptoms and airway inflammation concomitantly with a fast-acting bronchodilator and inhaled steroid. Inhaled corticosteroids and formoterol, which is a fast-acting LABA, is the preferred option as rescue and reliever or as maintenance and rescue reliever in the NAEPP steps 3 and 4. But it's also recommended in all GINA steps. Note that in step 2 in the NAEPP, the use of low-dose ICS either every day or as needed together with as needed SABA is preferred. As you can see in the GINA 2023 chart, SABA alone as rescue therapy is no longer recommended. There is a risk of severe exacerbations and mortality, which increases incrementally with higher SABA use independent of the treatment step. The use of ICS formoterol is currently not approved for maintenance and rescue therapy or for as needed rescue only in the United States. The recommendations for this ICS formoterol combination are based upon clinical data evaluating the use of ICS formoterol formulations and strengths that are not approved and not available in the United States. So this is what has caused a lot of confusion, but I want you all to stay tuned because there is a product that is currently approved, an AstraZeneca product. I think you've heard Air Supra, and it will be available in the early part of 2024. When track 1 options to include as needed low-dose ICS formoterol, a fast-acting LABA, are not available, GINA provides an alternative referred to as track 2 to include the concomitant use of SABA and an ICS as reliever option across all steps of therapy. This is referred to as anti-inflammatory reliever in the latest edition of GINA. So SABA alone is out. Anytime you're thinking about using SABA, encourage your patients to use an ICS. This is again a big shift in our thinking, and we have been pounding the pavement with SABA at step 1 since the early guidelines came out. So now let's shift gears and consider a newer way to look at these patients, because obviously we've been missing something. So this requires us to look at the bigger picture when we're assessing the comprehensive burden of uncontrolled asthma. The concept of asthma control is multifaceted. Asthma control consists of 2 domains, the symptom impairment and exacerbation risk. As asthma control worsens, the chance of an exacerbation increases. Now, the current guidelines recommend the use of asthma control questionnaires that address the impairment domain only. And this includes the ATAQ, ACQ, and ACT. The Precision program was initiated to develop innovative validated tools to improve the identification of uncontrolled asthma and educational resources for both practitioners and patients. I think by now you have one of these the AirQ by your at your table. The development of the AirQ involved cross-sectional and longitudinal studies, and the objective of the cross-sectional study was to derive the AirQ question scoring algorithms and cut points or levels of asthma control to validate the AirQ as a measure of asthma control relative to standard ACT score and prior year exacerbation. Remember, the ACT reviews the previous 4 weeks of asthma control, so you may easily miss an exacerbation if it occurred 5 weeks, 7 weeks, or 7 months in the past. The objective of the longitudinal study was to assess the ability of the AirQ to predict exacerbations over a 12-month period and to detect responsiveness to changes in asthma control when used longitudinally or over time. Asthma control is in the eye of the beholder. The standard of asthma control against which the AIR-Q was validated was a criterion composite of the baseline ACT score, which represents impairment, and chart documented prior year exacerbation, representing risk. The ACT and exacerbation outcomes determine 3 levels of asthma control. On the left side of the slide, you see well-controlled, not well-controlled, and very poorly controlled. And recall that the ACT measures patient-reported symptoms and impact over the past 4 weeks. So let's take a look at well-controlled. You have an ACT score of more than 20, 0 OCS use or an unplanned visit in the past 12 months, and a 0 hospitalization over the past 12 months. But look how the patient's level of control shifts if you account for a steroid burst, just one steroid burst, or a hospitalization in the past 12 months. All of a sudden, that score drops significantly. It's imperative to look at the bigger picture in front of you. There is another rigorously validated tool called the AIR-Q, the Asthma Impairment and Risk Questionnaire, and it assesses both impairment and risk. On the left side of the slide is the AIR-Q, a 10-item equally weighted yes/no composite asthma control questionnaire with 7 impairment and 3 risk items addressing symptoms, activity limitations, sleep, rescue inhaler use, along with helpful visual prompts and patient-centered social activities, exercise, difficulty controlling asthma, and exacerbations. The first 7 impairment items evaluate asthma control over the past 2 weeks. The last 3 questions, the risk items, evaluate OCS and systemic steroids, unplanned urgent care visits, overnight hospitalization over the past 12 months. The patient circles their response to each question, and the total yes answers make up the score, and they place this number into the box, and patients are assigned to a control category, these cut points that I mentioned. The combination of select AIR-Q items and control levels demonstrated a 90% sensitivity to identify well-controlled or 0 to 1 yes answers versus not well-controlled or very poorly controlled, and 96% specificity to identify very poorly controlled from all others. In other words, at either end of the spectrum. In my not too humble opinion, this is the new metric that should be in all offices, hospital systems, and Anna Betsy Bailey, our representative from Precision, has a booth out there. Familiarize yourself, and today's the day that you need to get educated to the importance of AIR-Q. The AIR-Q development and validation process included rigorous testing and statistical analysis to separate out or differentiate the different cut points to identify the AIR-Q score ranges that best represented well-controlled, not well-controlled, very poorly controlled, and well-controlled, not well-controlled versus very poorly controlled asthma. These are receiver operating curves. And again, I'm not a statistician, but when curves look almost this perfect, this illustrates the strengths of these statistical cut points. Again, this demonstrates high sensitivity and high specificity in the identification of patients at either end of the control spectrum. An AIR-Q score cutoff of more than 2 yes responses yielded a sensitivity of 0.90 to separate patients who were well controlled from all others, and an AIR-Q cutoff of more than 5 yes responses yielded a specificity of 0.96 to differentiate patients who were very poorly controlled from all others. Baseline data were analyzed from little more than 1,000 patients aged 12 and above with asthma participating in a 12-month observational study assessing the ability of the AIR-Q to predict exacerbations. There were statistically significant correlations between the AIR-Q and patient perception of overall asthma control, severity of asthma symptoms, and patient self-perceived health risk from asthma. As the AirQ control category worsened, so did the total and these other domain scores, demonstrating the construct validity of the AirQ relative to the patient's perception of asthma status, disease-specific patient-reported outcome measures, and the like. The St. George's Respiratory Questionnaire is a validated 50-item questionnaire that's commonly used in research studies and measures health-related quality of life in patients with airway diseases. It consists of a total score and component scores of respiratory symptoms, activity limitation, psychosocial impacts in the prior 3 months, and scores range from 0 to 100. Higher the score, looking along the y-axis, more limitation is noted. The correlations between AirQ and the St. George's Respiratory Questionnaire total and component scores were significant. Health-related quality of life is significantly related to the AirQ category. Baseline AirQ control level was predictive of the probability of time to first exacerbation. And it's important to recognize that all patients with asthma are at risk for an exacerbation, regardless of their level of control. This is a Kaplan-Meier curves and reflects a clear differentiation of time to first exacerbation by baseline AirQ control levels, as demonstrated in a longitudinal study of future patient-reported exacerbations over the subsequent 12 months. And you can clearly see a greater exacerbation-free probability over the 12 months when you're well-controlled versus very poorly controlled. We've just looked at a study reflecting the AirQ control level to predict the probability of time to first exacerbation over a 12-month period. But what about other future short, for example, 0 to 3 months or longer, 4 to 12-month term exacerbation risk? And many of us obviously evaluate patients far more frequently than every 12 months. So this forest plot shows that based on the longitudinal data, AirQ control categories over a shorter term or longer term are good predictors of future exacerbations. So for example, over 3 to 4 month period, the odds ratio for an AirQ control category of not well controlled shows these patients are 2.17 times more likely to experience an exacerbation than in the well-controlled category. In the longer term, take a look with a very poorly controlled, that goes up to 4 times greater likelihood of an exacerbation. And these findings are even more robust than the traditionally accepted demographic predictors of poor control in asthma, such as age, sex, race, and BMI. So importantly, recognizing the risk for future exacerbations, both provider and patient can implement appropriate changes in therapy to optimize control. The follow-up AirQ with a 3-month exacerbation recall period was developed to enable monitoring of control and assessment of management interventions between annual visits. The follow-up AirQ retains a 2-week recall for symptom-based questions, but has a 3-month recall period for risk-based exacerbation questions. The follow-up AirQ offers an opportunity to assess the impact of educational and other therapeutic interventions. It's not here to tell you exactly what to do, and it's not here to diagnose asthma, but if you've established this understanding, it's going to help give you some instructions, just guideposts to ask broader and more impactful questions. The follow-up AirQ shows construct validity. In other words, it accurately reflects what it's supposed to do. And this is to identify risk based on exacerbation history, health-related quality of life, measured against various St. George Respiratory Questionnaire domains, and patient perception of asthma control, risk, and severity. Asthma control in clinical practice is often overestimated because exacerbation history is not always appreciated. As I mentioned, asthma control is in the eye of the beholder. And here are patients who are in the AirQ exacerbation prediction study. Over 1,000 patients were involved, and they were asked to judge their level of control for themselves. Patients were also judged by subspecialists. I'm talking pulmonologists and allergist immunologists. And they were also rated by the ACT and AIR-Q. Let's take a look at the findings. And behold, of the 686 patients who rated themselves as completely or well-controlled, 220 of them had more than one chart documented exacerbation in the past year. Of the 601 patients rated by subspecialists as completely or well-controlled, 30% of them had more than one chart documented exacerbation in the past year. 540 patients classified by the ACT as well-controlled, and again, that's a score of more than 20, were found to about 29% had more than one chart documented exacerbation in the past year. And behold, when the AIR-Q, which assesses both impairment and risk, was found to be better at discriminating well-controlled. Out of the 387 patients rated as well-controlled, 60 or only 15% had more than one prior year chart documented exacerbation. Remember, prior year exacerbations are a strong predictor of future exacerbations. History repeats itself, and there may be consequences to overlooking prior exacerbations. Among over 1,000 patients with complete baseline control assessments and prior year and 12-month follow-up exacerbation data, more patients with prior year exacerbations who were rated as completely or well-controlled by baseline by themselves, physicians, or the ACT had exacerbations in the subsequent year when you compare it to the findings from the AIR-Q itself. Here you see all of the educational tools to assess the AIR-Q and the current precision educational resources. Anna Betsy Bailey will help you negotiate these opportunities. It's available in multiple languages, and AstraZeneca is really dedicated to support all of your educational initiatives. The burden of uncontrolled asthma in the United States is high, with projected future costs being substantial. Variability of underlying airway inflammation places all patients at risk who have asthma with uncontrolled symptoms and exacerbations. Patients, clinicians, and impairment-based control assessment tools may not appreciate exacerbation risk and the risk of chronic health conditions associated with corticosteroid exposure. The AIR-Q assesses both domains of asthma control and can help predict the future risk of exacerbations. The AIR-Q may complement current guidelines by facilitating the identification of unrecognized asthma morbidity in clinical practice. This is our post-evaluation survey. If you'd kindly point your phone to the QR code. AstraZeneca is committed to conducting business with the highest standards of integrity and professionalism. If you have any questions or concerns, please call this number. Don't shoot the messenger. And this concludes today's presentation. We have a great opportunity to really facilitate a tremendous alliance with all of you. And I'm grateful to AstraZeneca for allowing me to be a messenger of good news. And I've had the privilege to address you today. And thank you again, Wanda and Shelby, for inviting me to this fantastic conference. Thank you again for your attention.